Hi, and welcome to my presentation today on assessing sex differences in patients with stroke or transient ischemic attack when treated with dual antiplatelet therapy. I'm Presley, and I had the pleasure of working with a pharmacist, Dr. Logan Kelly at University of Utah Hospital. So a little bit of background. Dual antiplatelet therapy is a common treatment modality for patients looking to prevent a second stroke. Current guidelines don't actually talk about dual antiplatelet therapy used for secondary stroke prevention, and they mostly rely on controlling these modifiable risk factors. So this is smoking, hypertension, things like that, BMI. And so dual antiplatelet therapy does not go without its risks, but it is used frequently for secondary stroke prevention. So risks include, recurrent stroke or a major bleed with these agents. We really wanted to look into identifying the sex-associated differences in stroke and major bleed rates for patients with intracranial atherosclerosis and transient ischemic attack when they're treated with dual antiplatelet therapy for secondary stroke prevention. If we get into our numbers, we had our data warehouse from our EPIC EMR pull in about 375 patients. We applied our inclusion criteria, exclusion criteria, and we ended up coming out with a total of 89 patients. So this includes, if you look at the breakdown, 39 female and 50 male. Going into the nitty gritty of our population, we see, we had a mean age of about 69 years of age. Most of our patients had a BMI of roughly 27. We also looked at other things like smoking history, whether or not patients were on aspirin prior to this admission or prior to the admission for stroke. And then we also looked at dual antiplatelet therapy indication. So this is our transient ischemic attack or our acute ischemic stroke. As you can see, acute ischemic stroke definitely outweighed our transient ischemic attack patients, which makes sense. This is what we're using this for, and we see this in. We wanted to know what agents are actually being used. So as you can see, clopidogrel kind of blew everyone out of the water. There's only a few others in our set other than clopidogrel. We wanted to look at if they were loaded with dual antiplatelet therapy agent at admission. And we also wanted to see, how many patients were on medications that could potentially interact with these agents. So things like, PPI, so omeprazole, pantoprazole, things like that. And then lastly, we looked at a baseline of hemoglobin. This was mainly because of our other outcome of major bleeding event. We had to have the baseline hemoglobin to see if there was a drop in hemoglobin, essentially as defined by our major bleeding event. So if you apply all those things, we look at our results. So what did we come up with? We saw 10 and 10. So 10 patients had a recurrent stroke and 10 patients had a major bleed. Now, we do see a trend towards these outcome differences in men and women. If you look at the women in green, they definitely had more recurrent stroke. And if you look at the men, they definitely had more major bleeding events in our specific data set. Now, our specific data set was very limited. Like I said, we only had about 89 patients. Originally, we were planning to have about 300 plus patients. And so because of this, we were just limited on how much we could grapple with this data. So we strictly kept it descriptive and unable to run any further statistical analysis. So what does this tell you? Basically, our results just say we cannot accurately depict the truth about our bleed risk or stroke risk after we initiate dual antiplatelet therapy. Our data does suggest, however, that a difference may still exist between these genders. So, we saw a difference in our data set. What if we blew this up larger scale? Would we still see that? Definitely more research is needed. I think a larger data set is essential, and just looking at other things. I also think it's important to define things differently. For example, we defined a major bleeding event as a drop in hemoglobin of 2, or one requiring units of blood or fatal bleeding event. So necessarily a drop in hemoglobin doesn't necessarily mean they had an event, a clinically significant event. So this is something I think we could rethink for next time, or further research. But I think the big question to walk away from this poster with is, does dual antiplatelet therapy for secondary stroke prevention actually carry a higher risk of major bleed for men? And is it as efficacious as we thought in reducing the risk for recurrent stroke in women? I want to thank you for coming to my poster today, and please reach out if you have any questions. I would love to hear from you. Thanks.